Hi, my name is Airyaman Singh, and this is our pathogen presentation for scalded skin syndrome and Rocky Mountain spotted fever. For the pathogen nomenclature and characteristics, uh, scalded skin syndrome, the causative agent is Staphylococcus aureus. It is a gram-positive bacterium, meaning it stains purple on a gram stain because it has a thick peptoglycan cell wall. The bacterial cells are round, which means cockeye, and are found in grape-like clusters as the arrangement. For Rocky Mountain spotted fever, the pathogen is Rickettsia rickettsii. It is a gram-negative, so it has a thin peptoglycan layer and an outer membrane. It is shaped as Coccobacillus, meaning it is short and oval-shaped, and is an obligate intracellular pathogen, which means it must live and reproduce inside host cells, particularly the cells inside lining blood vessels. For the signs and symptoms of the disease, for scalded skin syndrome, early symptoms include fever, irritability, and skin tenderness. Soon the skin appears red and blistered, and on top, the layer of the skin can peel away with light pressure. If untreated, the damaged skin can lead to severe fluid loss, dehydration, and a high risk of sepsis, which is life threatening, especially in infants. For Rocky Mountain spotted fever, symptoms include fever, severe headache, muscle aches, and a rash that often begins on the wrists and ankles. If treatment is delayed, the bacteria causes vasculitis, meaning damage to blood vessels, which can lead to organ failure, tissue death, and even become fatal. For the transmission, for scalded skin syndrome, transmission occurs through direct contact with infected skin or respiratory secretions. In hospitals, especially newborn nurseries, it can be spread through contaminated surfaces or medical equipment if infection control practices are not followed to regulation and protocol. For Rocky Mountain spotted fever, transmission occurs through the bite of an infected tick. The bacteria enter the bloodstream when the tick feeds. The infection cannot spread from person to person, meaning it's non contagious, and the tick bite is required for transmission. For treatment and prevention, specifically for scalded skin syndrome, treatment includes nafcillin or oxacillin, and if MRSA is suspected, vancomycin is used. Sometimes clindamycin is added to help reduce toxin production. Supportive care includes IV fluids and pain control. Prevention focuses on hand hygiene, not sharing personal items, and strict infection control in hospitals. There is no current vaccine for this infection. For Rocky Mountain spotted fever, the treatment is doxycycline, and it must be started as soon as the infection is suspected from diagnosis for both adults and children. If doxycycline cannot be used, chloramphenicol is an alternative. Prevention involves avoiding tick habitats, wearing protective long clothing, using repellents, and checking skin and pets for ticks constantly when outdoors. There, again, is no current vaccine for this pathogen. For the epidemiology, in the general U.S. population, scalded skin syndrome has remained very rare, staying around staying around to about zero point 0.1 to 0.56 cases per 1 million people per year. However, amongst children, rates increase from around 3 to 5 to around 7.7 cases per million children, with infants under 2 having the highest rate at around 45 cases per 1 million infants. The increase is mainly due to better diagnosis and reporting and not due to the spread of the disease. For Rocky Mountain spotted fever, rates were around 2 million cases per million in 2000, increased to about 6 per 1 million people by 2010 as tick habitats expanded and the vector broadened its range geographically. And now appear to be to 3 to 4 per 1 million because the case definition became stricter, not because the disease decreased in showing up. For geographical prevalence and susceptibility, scalded skin syndrome is most common in infants and young children because of their immune systems and kidney function are not fully developed, which makes it harder to clear the toxin. Additionally, adults are usually only affected if they are immunocompromised, which means their immune system is just weak or not able to defend off the pathogen. For Rocky Mountain spotted fever is most common in the south central and southeastern United States, specifically North Carolina, Georgia, along that region of the country, especially in children under 10 and in people who spend time outdoors. The risk depends on tick exposure, not person to person contact, because again, it is non contagious. For the outbreak case study, a scalded skin syndrome outbreak occurred in a hospital maternity unit where 13 newborns were infected. The bacteria were spreading through staff carriers or contaminated surfaces. The outbreak was controlled using strict hand hygiene and cohorting, meaning grouping infected infants together to prevent spread. For Rocky Mountain spotted fever, 6 cases occurred in people exposed to ticks in Mexico, with 3 adults' deaths due to delayed treatment. The outbreak demonstrated that early doxycycline treatment is critical to survival if found in contact with this pathogen. Some interesting facts about these pathogens is Staphylococcus aureus often lives in the nose of healthy people without causing illnesses and showing symptoms. So some people might not even know they are transmitting it or have it. And also, the skin usually heals without scarring because only the outer skin layer is affected when showing symptoms of this pathogen. For Rocky Mountain spotted fever, ticks usually must feed for several hours to spread the bacteria. So a lot of unrecognition is like if you're caught with the tick, if you're unknowing of it, that's how it's transmitted. And pets and dogs can bring in ticks indoors, increasing human risks because they're more susceptible to outdoor and the woods and stuff. Some questions I might have for you guys is how can hospitals reduce the risk of scalded skin syndrome spreading in newborn units? Why are infants more vulnerable to this infection than adults? And then for Rocky Mountain spotted fever, my question would be what daily habits could reduce the risk of tick exposure? And how might delayed diagnosis affect the severity of the symptoms and results of Rocky Mountain spotted fever? Those are my references, and thank you.